In this video, I'm going to discuss the mechanism of pathogenesis of the Wilson's disease, and then after that discuss the clinical features, diagnostic tools, as well as the treatment options that are available for this disorder. So Wilson's disease is an autosomal recessive disorder that is due to the mutations in the ATP7B gene. And the ATP7B gene has two main functions. One, it's required for the excretion of copper from the liver into the bile. And this is done by the copper transporting ATP ACEs. And then the second function is to incorporate copper into the ceruloplasmin, which is a copper binding protein that is again required for the excretion of copper. Now, deficiency of the ATP7B therefore will cause accumulation of the copper inside the liver because the copper can no longer be excreted into the bile, and so patients present with the hepatic manifestations, which is usually the initial signs of the Wilson's disease. So therefore these patients can develop hepatitis. They can also have cirrhosis, liver failure, as well as the hepatocellular carcinoma. Now, the mechanism of toxicity of copper is through the Fenton reaction. So copper and iron are the two Fenton catalysts that can help convert the hydrogen peroxide into the highly toxic hydroxyl radical. So both hydroxyl radical and hydrogen peroxide are reactive oxygen species, but the hydroxyl radical is by far much more reactive than H2O2, and thus this hydroxyl radical will react with the DNA, lipids, and proteins and cause their destruction, as a consequence of which it will cause liver damage. Now, with the Fe or iron, there is a disorder that is associated with accumulation of iron, and can you recall what's the name of that? And that is hemochromatosis, which is associated with the accumulation of iron in the body, and hemochromatosis could be secondary to transfusion, for instance in patients that have thalassemia and require recurrent transfusions, or it can be associated with mutations in the HFE gene. In any case, with both of those conditions, there would be accumulation of iron, which will again act via the Fenton reaction to convert the hydrogen peroxide into the highly reactive hydroxyl radical. But in any case, for this video, I only want to focus on the Wilson's disease, but just know that both hemochromatosis and Wilson's disease, due to the accumulation of the Fenton catalysts like the iron in hemochromatosis or copper in Wilson's disease, can cause damage due to the production of hydroxyl radical. So continuing with the Wilson's disease, there could also be the deposition of the copper inside the cornea, as a consequence of which there could be Kaiser-Fleischer rings, which is shown right here. You can see that there is a ring around the cornea. And so this is referred to as Kaiser-Fleischer ring. And to diagnose the Kaiser-Fleischer ring, you will have to use the slit lamp, which is kind of a microscope that will allow you to have a close-up image of the cornea. Other manifestations include the CNS symptoms due to the deposition of copper into the CNS. So these patients, due to the deposition of the copper inside the basal ganglia, can present with the Parkinson's symptoms. Like for instance, these patients can have resting tremor, rigidity, as well as bradykinesia. And so in addition to these features, Wilson's disease have many other features, like for instance Kaiser-Fleischer ring, as well as the liver problems that can help you distinguish Wilson's disease from Parkinson's disease. But then if you also look at the age of onset for the Wilson's disease is usually about 20 years of age, versus Parkinson, which is about 60 years of age. So if you see these symptoms like resting tremor, rigidity, and bradykinesia in a 20-year-old patient, then you should more suspect Wilson's disease than Parkinson's disease. And then other features of Wilson's disease include cognitive impairment, depression, personality change, as well as psychosis. Now for the diagnosis of the Wilson's disease, since there has been liver damage, you can check the labs for elevated aminotransferases like AST and elevated ALT. There would be decreased production of albumin from the liver. There's also decreased coagulation factors. And as I discussed earlier, ATP7B is also required for the incorporation of the copper into the ceruloplasmin. So therefore, decreased level of ceruloplasmin is also another feature of the Wilson's disease. And then you can finally use the liver biopsy to check for the elevated level of copper inside the liver. And so these features can help you to diagnose the Wilson's disease, and then genetically, by checking for mutations in the ATP7B gene, you can diagnose Wilson's disease. But since the clinical features are usually sufficient to diagnose the Wilson's disease, therefore the testing for the ATP7B is usually used for diagnosing the Wilson's disease in the siblings. So let's say that there is a 20-year-old child that has these presentations, the ones that I just discussed with you, like resting tremor, bradykinesia, psychosis, and so on. And then you check for the labs, you see that all these numbers has been changed. So it kind of confirms the diagnosis for Wilson's disease. And then there is another younger child, let's say a 9-year-old child in the family, and you want to check if that person also has Wilson's disease. So what you can do is that you can check for the ATP7B gene in that person to see if there are any mutations. So again, genetic testing with ATP7B gene is another way of confirming the diagnosis of Wilson's disease. And then finally, for the treatment, you can provide with the copper chelators, like for instance, trientine, as well as penicillamine. And then one way you can memorize that penicillamine is binding copper is that penny is made of copper, so penicillamine binds to the copper. And then you can also provide these patients with zinc supplements, which activates metalloproteins that are binding to copper to help protect against the copper excess in patients with Wilson's disease. And that concludes our discussion.